Welcome, everyone. So this is going to be a super exciting webinar. As most of you know, I've been working extensively with peptide therapies for my patient population over the past 8 years, putting together ways by which to use them to modulate the immune response before I start to detox and before I start to treat infections, while I'm doing that and even after. And today I have with me Dr. Kent Holtorf, a dear friend of mine and Eric's and our colleague. He has thought, as you all know, I'm sure, deeply about peptides himself. He's behind integrative peptides. And he's also thought deeply about CERS, chronic inflammatory response syndrome.
It
And
sucks.
you know, to be quite frank, and we've had a lot of patients have a hard time with that protocol. And so he's really put together ways by which to think about this and address it using peptides, which makes me really excited as well. So welcome, Kent. So happy you're
Hello.
here.
Hello, everyone. And Fisa, thank you so much for having me on. I just love your seminars and all your summits that you have such great speakers, and it's an honor to be part of it.
The feeling's mutual. Let's dive
And
right
I
in.
have to apologize. I'm kind of whistly. My Mexican hairless dog, we collided and knocked my front tooth out. So I got this Amazon tooth in my ear. So it's okay. We put her to sleep,
Oh, I'm
but
so sorry,
I'm
Kent.
I'm kidding. I'm kidding.
Okay.
No, she's still here. But anyway, so I'm kind of it's really weird to speak with it. But anyways, yeah, so I wanted to kind of I found that we had so many CERS patients and they just kept saying, "Oh, I'm on these binders." And I said, "How long have you been on?" I'm like, 8 years. Like, "But I know I'm gonna get better." I'm like, ah. So I really wanted to look at it and see how do we, basically Shoemaker's done so much great for the CERS community and so many other things. But there's just ways to speed that up and kind of go more upstream instead of just doing downstream binders to speed everything up. And I'm too ADD to wait 8 years to get patients better.
Right. What I've noticed is that using peptides the way I do and the way you do, patients who would have taken 5 years to treat it now, it cuts that in half. 2 years. Someone who would have taken one could be 6 months to 8 months. I mean, it's miraculous for
And
me,
some, it's just like weeks,
right?
Yeah.
Yeah, it's amazing. So there's no need to wait. I'm just going to tell our audience today how we're going to do this webinar. So Kent is going to show around three to five slides at a time between each chunk of slides. Him and I are going to talk. We're going to do that for a half an hour, and then we're going to open it up to Q&A for everybody else. But Kent, will you start by uh, telling everybody how specifically you have seen CERS uh, either fail, like do nothing for your patients, or flare them, and then if we go straight into your slides.
Yeah, we kind of have a Sears clinic, kind of anything that's untreatable or controversial or multi-system standard care is works well for if you got a broken leg, something simple. But if it's complex, the doctor can't treat it, so he blames you. He blames the patient. So, and I was looking at, Shoemaker's done so much great for this whole development of the treatment protocol, but something was missing. And so again, stand on the, shoulders of giants. He's a giant. And so we just added peptides to it and looked upstream what the dysfunctions are. So we're addressing more of the root cause rather than waiting to just like, for instance, fix the immune system by binding up the mycotoxins. That takes forever. Let's just fix the immune system, fix the mitochondria. Now you can detox.
Can't look
With no
at the
mitochondria,
camera.
you can't detox.
Kent, can you look at the camera?
Oh, sorry, I'm looking at
Thank
you.
you. Okay, keep going.
All right. And yeah, and so we want to, fix the underlying problems and you get such a better response and a much quicker response.
Yeah.
So
I,
I wrote a book. I have a bunch of books, 90% written. I never finish them. I just keep adding, adding, adding. And then this was the updated peptide protocol for the rapid treatment of CERS. And it wasn't done by any means. And then Gina, my assistant, stole it and then published it. Well, it was probably good because by the time who knows what when I would get around to doing it. Move that over, would you? Um, so yeah, so that's kind of what it is. It gives a protocol for adding the peptides, and really we find, and we're kind of immune modulatory center, and the same underlying pathology works for every chronic illness and anti-aging. I gave a talk at a conference a couple months ago, showed that acute illness, where the way we treat it, not standard, but is the same as anti-aging. And because it's the same dysfunctions, as acute dysfunction, you basically have a phenotype, like your immune system is a sick phenotype, an age phenotype. So you modulate that, and all of a sudden, it's much easier to get things better.
Great. All right, Kent, will you start with showing us your slides?
Yeah, so with one thing is like, VIP is kind of the pinnacle of the shoemaker protocol. And the problem is, it actually is instead of, we always want to raise TH1 and lower TH2, which is the inflammatory side, and the TH1 is the side that can fight the infections, fight cancer. And with CERS, really any chronic illness, aging, the body goes like this. So that the TH1, the natural killer cells, all the cells that will kill these infections basically get suppressed. That's how they work. But then you get high TH2, so you get autoimmunity and inflammation. Now, VIP makes people feel better initially, but what I found with it and looking at the literature on the mechanism of action, it keeps people from fully getting better. So people on VIP, they may feel better, but as soon as they're exposed to mold or anything, they just crash. So I'm not a big fan. If you do it, for a short term, for a short period of time. So the core abnormalities, everything's a vicious cycle in medicine. So and I found that CERS patients, they say, "Oh, I got a mold exposure." A normal person typically does not get sick with CERS by being exposed to mold. They have a deficient or dysfunctional immune system to begin with. Typically Lyme disease or some sort of chronic infection or even severe stress or aged. And it just basically, and then it becomes what is really causing it, just worsening immune system, mitochondrial dysfunction that we'll talk about. You get T cell exhaustion. And this also happens in cancer, but the cells are there, but they just go, if you have a stimulus, let's say it's mold over time or even autoimmunity, the cells just go, it's been there, forget it, we're not going to work anymore. So it's a big thing, and they're doing all these kind of toxic meds to try to stimulate these things, but we've had them. There's like Thymosin Alpha 1, which is approved in 54 countries to raise TH1 very safely. It got banned because they made the mistake of coming out showing that they were safe and effective against COVID, so they banned it because they couldn't do the vaccines. Um, but also Thymogen Alpha 1. I'll talk about these things. You can do oral ones, but really getting that immune system back. For instance, when I had, CERS and chronic Lyme, Babesia, Bartonella, I had 3.5 years of IV antibiotics. Didn't get better. Was in the hospital with sepsis. And I remember the nurse changeover, and they're like, this is that AIDS patient, keeps up turning negative for HIV. And because I had no immune system. And once I found peptides and raised the immune system, because if your immune system isn't there, antibiotics can only knock it down so much, or antifungals. Immune system has to be high so then it can take over. Immunosenescence with more to do with aging, but it also occurs there. So that's, everything's a seesaw. And natural killer cells are key, and they're the number one thing that's gonna basically a marker. We use that for a marker of sickness, how bad you are, as well as C4A and human transitory growth factor beta. But usually they have the numbers there, but they're infected, they're dysfunctional. So if you do LabCorp, it'll give you a number which doesn't correlate very well unless it's really bad. And the problem with Quest, they have natural killer cell activity, but they screw it up about 70% of the time. But it's a key marker. So if you want to talk about that.
Kent, I think this is a good place for us to just chat and we can go
Yeah.
over the next batch of slides. Um, so I think I'm just seeing some questions pop up about what is CERS. It's chronic inflammatory response syndrome, and it is, we promised you would be talking about mold and detox, and it really is in reference to mold treatment. But Ken, I think as you and I have spoken so much privately, right now we're like bringing this out public, what we've said in private about modulating the immune response. I think that a lot of people are forgetting that we actually or can modulate the immune response before we start to treat all the infections, before we start to detox. And then once we do treat the root causes, we can do that with peptides. Then it starts to retrain the immune system and the nervous system. Um, I'd love to hear your thoughts on this piece, particularly as it
Yeah,
relates to fears.
there's so many upstream things, and we're kind of a immune modulatory clinic, and every sickness, age is basically immune dysfunction is driving everything.
Yeah,
Fix that, everything else can come in line.
yeah,
Because when you get this immune dysfunction, you end up with mitochondrial dysfunction. And for instance, everyone wants to detox. I guarantee everyone on this call that is Sears has mitochondrial dysfunction. And studies show they'll have like cells with, let's say, heavy metals in it. With mitochondrial dysfunction, there's not enough energy to expel that. And so you need to provide the mitochondria, basically stimulate them. So now you can get rid of these things. So now you can actually detox and not take 8 years.
yeah,
It's interesting. There was a study on autism. They gave them just 1,200 milligrams of CoQ10, which is very basic. We have way better treatments. Excuse me, significant improvement over a few months with just doing that.
yeah. Normally, I'm giving my patients mitochondrial stimulation after I've dealt with immune modulation, even after I've dealt with their multiple causes, because I think of the patients being their mitochondria being stuck in stage one of the cell danger response, where they've got the mitochondria creating oxidative stress, they're creating inflammation. It should have been transient to contain the insult, but now they've got this persistently because that's where the patient is stuck. But if you give them, say, MOTS-C early on in treatment, I tell them it's kind of like tickling an angry person. They're not going to find it very funny, right? The mitochondria are going to create more oxidative stress and inflammation. But I'm thinking a lot about SS31, how that's mitochondrial healing and how giving that early on is not stimulating the mitochondria when they're already
Yeah.
creating things
Have you
right.
had an issue with MOTS-C or just theoretical?
Both. I've had patients
Yeah.
like that. You know what? MOTS-C early on, no.
Yeah. So what I would do is do a senolytic protocol.
Mhm.
Because the dysfunctional basically zombie cells, the mitochondria turns on you as you're talking about. They start secreting reactive oxygen species instead of oxygen.
Yeah.
So you want to get rid of those cells. T cell exhaustion is reversible, but you want to get rid of those cells. So you can do a senolytic program, either use FOXO4 DRI peptide
Yeah.
or dasatinib and fisetin, and we'll
Yeah.
just do it continuously 3 days a month. And that gets rid of those zombie cells that are basically taking the MOTS-C and SS31, the PQQ, even BPC, TB45, all those things that boost mitochondria, and they're gone. So you don't get
Yeah.
the reaction.
Yeah, absolutely. Okay, show us your next set of slides, 'cause I think now you're going to get into the therapy.
Yeah, and so on the second part, which we'll do at some other time, I go through each bioregulator and have clinical studies on the benefits and the outcome of each one. But we don't have time for that now. But so really kind of a new paradigm, and really again, we'll treat anything that's so-called untreatable. We got ALS, dementia, of course, chronic Lyme, babesia, CERS, MCAS, cancer. We're doing more cancer now. We just reversed this guy who had bladder cancer. They said it's too invasive, too aggressive. They're just going to take out his bladder and his prostate. And they went in. I said, "Give me 2 months," because that when his surgery was scheduled. And at 2 months, they basically went in and said, "Cancer's gone." It's a miracle. He wouldn't believe it had to do anything to do with what we did. But Yeah.
Of course
So
not, right?
yeah, he's doing great. So the key is restore that thymic function, and that the thymus will basically there's the pineal, hypothalamic, pituitary hormone, and then you have thymus axis. They're connected. Thymus will control that Th1, Th2, or Th1, Treg, and Th2, Th17. So you want to restore that, and we'll talk more about that. Reverse that T cell exhaustion with the typically thymic peptides, restore barrier integrity, things to restore the gut-brain axis and the blood-brain barrier, BPC, KPV, Akkermansia, the oral IVIG, immunoglobulin. And then you want to boost mitochondria, so now you can actually detoxify because your body is just struggling to detoxify. It will just speed everything up. And for instance, I like to do, and the problem is like with SS31, what kind of doses do you do? Um,
I can't remember, Kent.
yeah, but in MOTS-C,
Okay.
it's kind of limited by cost, but MOTS-C you can do every day, but most people do it twice a week. It's still very effective. And then
Yeah,
SS31, people are doing 5 mg, 10 mg. Really, the studies are 100 mg, but and very, very safe, and it's just a great med. But any amount you can get works, and it restores. Yeah, it heals. Or MOTS-C kind of stimulates, right?
right.
Where which is good in some instances and not so good in others. But the SS31 will basically heal that inner lattice of the mitochondria.
Hmm.
And everyone has mitochondrial dysfunction. Just from
I
toxins,
do.
pesticides, plastics, and CERS, it's just terrible.
It is.
And so here's the thymic. I'm sorry, the fonts didn't really transfer over, but a normal person, and then the lighter line here is a CERS patient, but it's even worse. It goes way down here. So, why peptides? So they're biosignaling molecules. I don't know. Have you talked about peptides versus bioregulators in the
I had talked about it at iLabs just the other day,
Oh, I
actually.
I, I hadn't I
Yeah,
missed it. But yeah,
I
so
know.
peptides, like insulin and GLP-1s, but so if they're less than 50 amino acids long, they're considered a peptide. Now there's a subset of peptides called bioregulators, which are only 2 to 4 amino acids. Now peptides generally work, they go into your body. Most of them need to be injected except for BPC when it's capped, acetylated and amidated. The arginine BPC is much less bioavailable. But the bioregulators are so small, and when they're capped, the body will cap things when it recognizes, hey, we need these. We don't want to break them down in the gut. But that also makes them much more absorbable, and they go into the cell and then attached to repressors or activators of genes. So they're very epigenetic, where peptides go to the cell surface and cause multiple effects inside the cell. So they work very differently, but they're often lumped together. So, BPC 157 is kind of the go-to for so many things. People think of it as the gut peptide, body protection compound 157, but it works for joint pain, it lowers inflammation, it helps with brain, gut brain, all that. Now, looking at really you want to fix the that Th1, you want to fix that immune system. And so we have, if you want, you can do Thymosin Alpha 1, TB4, although TB4 actually stimulates mast cells. So that can be a problem. And TB500 stimulates mast cells. So I would watch out for that. And people just throw TB500 out there like, it's the same. But so
Yeah.
we made a product to be more potent than thymosin alpha 1. It's thymogen alpha 1, which has Vilon and thymogen in it, which are two bioregulators that boost the that Th1 and lower Th2. And and even people with CERS patients that can't tolerate even BPC, which a normal person is just like, oh my gosh, how could you not tolerate it? can often tolerate KPV. It's a unique peptide in that it's very anti-inflammatory, but it boosts your immune system and it's antimicrobial. It's shown to be more potent than amoxicillin against staph and also against fungus. So more potent than diflucan. And then TB4 frag is the fragment of TB4, which is the immune modulatory fragment, but it leaves out the part that stimulates mast cells. And there's a lot of studies, and that would be in the next lecture, where we go through these studies showing it rejuvenates the heart and post-MI, brain, basically post-stroke and all those things. So a lot of cool stuff. So really resetting the command center. The pineal controls everything. And we have a thing called pineal pep, which has epitalin in it. So epitalin is the pineal peptide. It doesn't have pineal. Well, pinealion, people think is a pineal peptide, but it's subcorticopeptide. So that's in our cognipep. So it goes subcortical, which it will influence the pineal. They all influence everything. And then the pineal, the hypothalamus, the pituitary, then it goes from there. Uh,
Let's stop and chat a bit because there's so much juicy information here and even more questions are popping up. And don't worry, everyone, in about 5 minutes, maybe 10 minutes, we'll get to the Q&A. But the MCAS part, I think, is really, really important. What I notice is that I have to actually, I'm using lorazepam to heal a leaky gut, bring in amlexinox, then KPV, and then using whatever else I'm using to modulate mast cells before I'm coming in and doing the other things, like using thymosin alpha.
I like that.
Yeah, yeah, I think it's really helpful. Kent, what do you think of doing more than five, less than 10 of the slides, and then we open it up to Q&A?
Sure.
Yeah, and then we
Yeah.
promise you we're gonna, we think it's only fair to you that we go get through all of his slides. So Kent and I will do
Yeah.
some
No,
more of these.
I don't think there's many left on this
Yeah,
section.
okay,
Yeah.
cool. Okay, keep
I
going.
don't know what number it is. But all right. So mitochondria, we talked about MOTS-C, SS31, and humanin is another great one. So humanin is named humanin because it made Alzheimer's patients human again. And it has been stuck in phase 3 trials for decades because they're paying for it not to come out. In the meantime, they're approving all these crappy meds. So we have, cerebral lysin, C-Lank and C-Max, which are injectable or nasal, and then Cognipep and CerebroPep, two oral peptides with bioregulators in them for brain function. And this all, I won't go over this, but it just kind of compares it goes through each supplement or each peptide or bioregulator and talks about what it is so that they can look at that. And there was a break. But so one thing, remember immune activation of coagulation. So the body in response to inflammation or infection, and this is part of the immune system, it will actually try to surround the invading bug, whether it's fungus or bacteria or parasite, in fibrin. And then it will start shooting antimicrobial peptides like LL37 into that section. But like Lyme has evolved, it wraps itself in fibrin, so it can't be seen. But if you clean this up, because it lays down fibrin on the cells, and so now nutrients can't get in, waste products can't get out, and oxygen that normally takes 2 seconds to get in the cell can take up to 2 minutes. So people get that air hunger. So sometimes we'll give them heparin and like lumbrokinase, nattokinase. We have Fibernex, and all of a sudden, after 2 weeks, they're like, my shortness of breath is gone, and they've been through all these pulmonary, tests and cardiac tests. So yeah, you really, and it talks about what labs to check on that, but almost everyone is, and there's a parlor trick you can do, but yeah, so heparin, fibrin, like enzymes, BPC, copper. And I just want to mention that everyone's low thyroid with CERS, almost everyone, I should say. And the TSH gets suppressed because of the pineal hypothalamic pituitary dysfunction. So do not rely on your TSH or standard blood tests for fixing your, because oftentimes T3, all you need is that, and all of a sudden they feel so much better. And we have our nonprofit National Academy of Hypothyroidism, nahypothyroidism.org, and lots of studies on there. And then it's kind of
Can I stop you for a sec? I'd love for you to tell them about ThyroPep.
yeah. So, and that was in the next section, but I'll just mention it briefly that thyropep, so there's a thyroid bioregulator. We have the study showing that if you take it, it will, and you have low thyroid, it'll raise it. If you have high thyroid, it'll lower it. And the study with the thyroid bioregulator shows that it will raise T4 and T3 with hypothyroid patients or Hashimoto's patients, but it doesn't touch the antibodies. So we came up with the thyroid axis bioregulator thyropep, and it not only raises actually to more of an extent than the thyroid bioregulator, but it also will modulate the immune system and lower those antibodies. And the studies show quite significantly.
Right. And I've seen that once I get my patients on that, I can start to begin to lower their thyroid hormone dosage, you know? So it's pretty amazing. You
Yeah.
want to share a little bit more before we open up to Q&A?
Yeah, let's see. I'll just see if there's anything. Yeah. So I think the most important biomarker is human transferable factor beta. And it causes fibrosis, it causes hypercoagulation. So that is a marker. And again, LabCorp is inaccurate. Unfortunately, Quest and their terrible service, but they're more accurate if they actually do it. That was just about the VIP again. This just looks at the difference between the two. These are just kind of overall stuff that they can get a copy of these. And then, yeah, so protection, you want to really, before you eat, or even, with you do binders, make sure your mitochondria is good. You got to really boost that. VIP, the TSH is unreliable. Um, where'd it go? Oh, I think I lost it. Um, wait, six. Well, I think I screwed it up into the same slide, but
That's
there's
okay.
six, there's five more. But I think that's now it's ready for part two.
I just want to talk about VIP for a sec. I've seen many patients who, prior to coming to me, they took VIP and it made things worse. I'd love for you to explain to people why that would be.
Yeah, and so I hear, VIPs on the top of the pyramid, it's the ultimate to get to, right? And he does say only do it when you're, basically have no symptoms or something. But I looked at the mechanisms of action, which doctors tend not to do, but it does the opposite of the things that benefit the patient. I'm like, this makes no sense. It raises that TH2 and lowers that TH1. Now it kind of lowers both, but it more like this. So patients can feel better. But we find that people have been, oh, I'm doing great. As soon as they get near anything, it could be perfume, mold, they just crash. So they never seem to be able to get over the hump because the immune system is stuck.
Right. I also think, a lot of these patients have multiple colonizations in their sinuses that don't belong there. I'm seeing a lot of funguses or microbes that really should belong in the bugs that should belong in the gut, in the sinuses. Um, I think that when you're spraying something in there and you've got colonizations, it's not going to work necessarily because they're creating persistent inflammation or they're creating mycotoxins that then cross the blood-brain barrier. How can the VIP help? And I think that's an overlooked piece. Or like when people spray C-Lank and C-Max in their sinuses, but they still have some kind of mold in there. A lot of them
Yeah,
do.
well, the nasal will get up in the olfactory nerves and get
Yeah.
brought more to the brain. Yeah.
Yeah, I want to wait until I've cleared their sinuses before I start giving them that because I noticed it didn't work.
And I like about so Cmax is more activating, C-Lank is immune modulator and also calming, which most people need, including myself. Like when I'm stressed, I'm like, where's my C-Lank,
Yeah, yeah,
But yeah, so they're actually good.
yeah. I think we should open up to Q&A. Okay, Here's a good question about the difference between peptides and bioregulators. Um, and he explained, Dr. Holtorf explained this, but I'm going to do a quick explanation again. So peptides sit on cell surfaces in receptors, and they're very specific. And then they are cell to cell messenger molecules. So they sit on the receptor, and then that then instructs the cell to then communicate to other cells inside that same system or in other systems. And the bioregulators, they're so small, they're only 2 to 4 amino acids. They go inside the cell and they heal the tissues of that specific system, and they work on epigenetic expression. When would you use one versus the other? For me, and now that I can make them available thanks to Kent, okay, or now that I can make them available to my patients easily thanks to Kent,
We have more potent ones coming out,
yeah.
but
I'm actually using them for my patients now prior to using peptides because my patients are highly sensitive people. And I tell them, you know what? It's not that these are simple in the way that they behave when they're in your body or in their mechanisms. They're simple in their structure. So patients who have mast cell activation syndrome or hypersensitivity, they're less likely to reject them. So starting with those, and then I'll move to peptides. How about you?
yeah, and often I agree with that. I'll start unless they're totally when someone says they're sensitive, you gotta listen. But I with a sensitive patient, I probably start five together. That's why we're trying to combine them so you don't have to take so many. But some will do 10 bioregulators. And so bioregulators are more slow on, slow off. They'll work over time, where peptides are more immediate. Yeah, so you kind of ease them in and kind of, get some benefits so they can tolerate the peptides. I totally agree with that. And I just saw the question about plasmapheresis. So you guys got plasmapheresis in your play. I love plasmapheresis.
Yeah.
How is that going?
It's going wonderfully. The thing is, people want it to be a like a one and done or a the end. Someone said to me, "Lads, it's the end all be all," and it's not. If it's done on its own, I think it's kind of a waste of your money. You need a lot to support your system while you're doing it. So peptide therapies, I think of them as I scallop my patients treatment,
Yeah.
scaffolding for that plasmapheresis to actually for its therapeutics to take a hold, that and different intravenous therapies, making sure the patient doesn't have a toxin load that's coming at them still. Ken, I want to ask you about your favorite peptides for detox because we promised them that we would talk about it.
Yeah.
It's in the title of the talk. What do you like to use?
Yeah. Again, it's immune modulation and mitochondrial function.
Yeah,
All of a sudden, you'll be able to detox, much better, much quicker, even with the same binders and that, because you need the energy to detox.
exactly. And then once that's supported, then you can begin to your system begins to do what it should naturally be able to do. A lot of these patients are slow at detoxing anyways. They've got a lot of suboptimal SNPs in their genetic pathways for detox or missing glutathione SNPs, right? So we can then use peptides to
Yeah,
support.
it's kind of very similar to the autistic kids. And they
Yeah,
said, oh, they don't have heavy metals because they did urine tests because they're easier to do in autistic kids, especially. And they go, they don't have heavy metals. No, they don't excrete heavy metals.
exactly. Just because you're not seeing in the urine. In fact, when I'm not seeing toxins in the urine, whether it's metals or glyphosate or pesticides, if I'm not seeing it in the urine, I'm very suspicious that they're hoarding
Right,
those
because
toxins.
everyone they're just so prevalent everywhere,
Yeah, especially when you look
ubiquitous.
next to their genes. I mean, it's so telling. Um, Someone is asking, what do you think about food-based bioregulators versus synthetic ones?
Oh, good question. And we use both in our combination products. But yeah, the synthetic ones, and they both have some studies on them. Synthetic's more precise, so we can gauge the amount exactly. And so, in the natural, where you really have to rely on the manufacturer, right, and clinical, results to make sure it's okay because you can't test them because there's so many other stuff in there. But normally they're less than 10 kilodaltons. So basically they should be the active peptides are less than 400 kilodaltons. Um, and so, but they'll do 10,000. So there's a lot of other stuff in there. So the ones that we're starting to supply now are actually less than 2,000 kilodaltons. So you're gonna have much higher levels of the active. But yeah, so it's there. You can't really test them. They'll have some of the same structure as in the synthetic, but the synthetic we can, guarantee the amounts in there.
Okay, thank you. Here's a question, and this is a question that I get from many, many patients who are new to me, and I think it's really important we address it. I have severe long haul COVID and have had a great many specialists, but only one has put me on a peptide, BPC 157, for mast activation syndrome. I've not seen any improvement. Any thoughts? Yeah, I have many, many thoughts. I'm sure you do too, Kent. Um,
Oh man,
oh,
it's a whole nother, you know what though? It's the same basic premise as treating long haul COVID. We had one, I didn't know one of our MAs had long COVID and we had like a party. She showed up and she was just wiped out and she woke up in the morning, I can't get up, I can't breathe. And I just gave her a shot of like 6 or 7 peptides. She's like, oh my God, I feel so much better. So it's like give me the protocol for Lyme disease or give me the protocol for CERS. Like there's so many things. And also it's looking like there's still spike protein in there. So ivermectin, lumbrokinase, nattokinase, and to dissolve that is one factor, but everything else is the same. The immune system's even worse. And usually I find people are basically not long COVID, but long vax
yeah.
which is it's much more likely. And they all have, and we have a live cell, and we just looked at our patients. They were well, but they got vaccinated, got the V, whatever I should say, and their coagulation just dramatically is huge. We checked their coagulation directly, every single one, I think, except for two didn't have immune activation of coagulation.
Yeah.
And the studies are coming out now, and the cases that they, basically like a 7-year-old, less than 24 hours after the vaccine died, and they didn't look into it, and they're saying, oh, there's no proof, it could be anything. Like it's just it's criminal.
Absolutely.
Oh,
Yeah,
and
not
a
only
study
that.
just came out. They
Hmm.
showed finally they would never do this. So the someone who works closely with the vaccine manufacturers and the CDC did a study, well done, looked at people who were never vaccinated, whether it's Amish and all that, versus people who are vaccinated, how healthy they are. It was half the mortality over 10 years in people who are not vaccinated and 4 times the risk of chronic illness, autoimmunity, basically allergic reactions, mental illness in the vaccinated. It's
And
crazy.
if you can send us that link to that paper, I bet you a lot of people listening here want to see that.
Yeah, I'll
Yeah.
promote. It's Deltree.
Oh yeah,
Uh,
yeah, yeah.
yeah. And so
Del
he
Big Tree.
the big tree. Sorry,
Yeah,
Deltree. Yeah,
yeah.
I
I knew
combined
what
it.
you're talking about.
That's his nickname. No. So he has a documentary out, which is free right now, and I recommend everyone go see that.
Yeah. So I also,
It is the inconvenient study.
yeah, yeah. Now, people, I think, just use BP-157 as the golden child of peptides, right? And then, and then wonder why the peptide didn't help. It's because, in my experience, one peptide isn't going to help. It's having them work together. We're looking for multiple signal pathways to be replenished and rejuvenated through those peptides. So if you're just using BPC 157, I expect it to do not much for you if
And
you have
depends on where you get it because it may not
yeah,
be absorbed.
yeah, yeah.
Because Lori at the conferences, she sees anyone limping or anything wrong. Hey, come over here and gives them like 8 BBC. Take 4 tonight, 4, and then come back.
Very
And I
generous.
I don't think there's anyone who hasn't been better. But
Yeah,
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 usually it helps somewhat. Nothing works for everyone, but really
yeah.
the power of peptides is, and you look at meds when you start stacking meds, exponentially the interactions and side effects go up. With peptides, they don't.
No, they work
Work much
together.
better together.
Honestly, in this patient population where there's multiple inflammatory disease processes taking place in multiple systems of the body, we need multiple bioregulators targeting each of those systems, and then multiple different peptides that are actually turning on the different cell-to-cell communication pathways. Honestly, I often don't need anything else other than peptides for the first 3 months of treatment. It makes everything else go so much faster.
Yeah, yeah, you prime the
I'm
wheel.
priming, yeah, absolutely. And then when we're thinking about long COVID, there's I think of it as well, there's many subtypes, but broken out into two subtypes. One type of person with long COVID, a peptide stack might work because all they have is COVID-related issues. They've got spike protein or viral reservoirs. We can test for those. They've got microclots. We can test for those. They've got inflammatory cytokines that are related to long haul COVID itself. We can test for those. And then we test for other things. Oh, look, they don't have Lyme and co-infections. They don't have a mold issue. They don't have an issue with glyphosate and mercury and lead. Well, how many of your patients are like that? Not mine, but those are the patients who they can just take a stack. They can take the blood vessel bioregulator. They can take some TA1 and call it a day, and they're good, right? But the ones who come to us, if you just try and give them a stack or a peptide here and a peptide there, it, it's not going to be healed. Everything has to be highly, highly patient specific. Um,
But someone asked
so
about for cancer, they said KPV or thymogen alpha. Um, I would say, yeah. So thymogen alpha 1, which is or thymosin alpha 1, either one. But I got a whole cancer protocol again that we reviewed, but I would start on high dose ivermectin and fenben. Again, I'll leave it there. And it's Laura Frontiero. So I'll get back to her.
okay, great. Um, Someone's asking, can peptide treatment help with autoimmune gastritis, with focal atrophic gastritis, with intestinal metaplasia, gastroparesis, and so gut transit, and small intestinal inflammation? I have pernicious anemia. I'm exhausted and just done a mitochondrial test with ALNM and Lyme testing awaiting results. So,
Yeah, and it's not just the gut, it's a multi-system illness.
yeah.
Yeah, peptides are great for gut. We had, so many patients. The one that comes to mind is a 7-year-old. They're going to take out her colon, um, and for Crohn's, and there's like, oh, there's nothing else left for you, and we reversed it in like a month. And
What
so you
do you
have to
do
get her
for
colon
them?
taken out. So yeah, peptides are great for immune modulation and the gut especially.
Absolutely. What did you do for that patient?
Yeah, really, she was very hesitant. And we started on BPC and she probably got 50% better. Then we added KPV and TB4 frag, and then not much else after that. And I think gut feeling, where it has the Akkermansia and the Munilin, and she's great. In fact, she showed up at the office. This was a number of years ago, and I didn't recognize her as bad, because she was growing. She wasn't growing, and she was just so tall. I didn't recognize her. And it's funny. She went to dinner with a friend of hers. And she goes, "Oh, said, oh, how's your daughter? Well, I went to this Dr. Hawthorne." And he goes, "Do you know him?" Like, what? He's like, "Holtorf?" He goes, "Yeah." She goes, "Do you know him?" He goes, "I work for him."
That's great. Kent, here's one for you. Someone's asking, can you still do this protocol if you aren't sure what your actual diagnosis is? A lot of autoimmune symptoms ever since the vaccine.
They're all the same. I mean, they're all the same pathophysiologically. And that's the thing. We have all these syndromes and they break it down to here's this, here's this, here's this. They have the same underlying pathophysiology. So, yes, you're not going to hurt yourself by any means. And it's going to, there's nothing, and we're going to write a book about this, but there's nothing that doesn't fit the model.
Right.
Nothing.
Because really, how do you get that end diagnosis? It's about persistent inflammation meets the genes. Then we get that downstream diagnosis, ME/CFS, long COVID,
They
chronic Lyme,
exactly every single
fibromyalgia.
one has immune dysfunction, basically pineal hypothalamic pituitary hormone dysfunction, mitochondrial dysfunction, immune activation coagulation. At least majority of those. I mean, so they all have the same underlying that causes it's the unifying, like the unifying theory of gravity, right? In physics,
Yeah,
but it's the same, and that's the talk I gave is like we're separating all these things, and they're the same GD
absolutely.
thing.
And all the doctors work in their silos, each ologist. And I think it's
Uh,
important our patients see the
or it's
ologist.
like the gastroenterologist. All they do is scope everyone. Okay, here you go, and like, oh, probiotic. Well, I don't know, you
I
know.
mean, one patient told me that she didn't want to take her probiotic because UCSF told her that that could be bad for her in pregnancy.
Oh my God.
Yeah.
You
So
know what? I
no
hear more and
probiotics.
more. It's just like, oh my God.
Someone is asking where we can see your protocols. Before you tell them that, Ken, I just want to say something about myself. I think the same is true for you too. We might create protocols like the CERS protocol, but we cannot apply it cookie cutter way, one size fits all, because it's not. Once it's complex, it's chronic.
Yep.
It's the expression of your own illness and the expression of your
And we're getting more
diagnosis
and
will
more
be different.
individual. Yeah.
Yeah,
And I've
exactly.
always hated protocols, but patients love protocols,
They
doctors love
do.
protocols.
So
So
so we're like, all right, here
we're working
here's
on an AI agent that you
uh-huh.
could just plug in everything you know and it will spit it out. So and that's because again, you look at the what's protocol for Lyme, for Sears, it just ends up being, well, if this, that, da, 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 it ends up being so gigantic that you can't give every, potential scenario because everyone's different.
Yeah,
Everyone's the same, but also everyone's different. And so I'm realizing people need protocols, so that's what we're developing this agent that hopefully will work. Well, we'll see. But yeah, to solve that problem because it's really needed because people are just confused. This doctor says that, the doctor says that. Everything's so confusing for doctors. So I agree. It's a
yeah,
big lapse, a big
yeah,
missing part.
yeah. So while we might give you a protocol, we're really dancing with you. Okay,
Yeah,
so
and you're always like altering the protocol is the thing. So if you
always,
go here, take this, you'll be better. Then they get to step three and they're like, ah.
yeah, yeah. We have time for one or two more questions. Can someone wants you to repeat the senolytic protocol that we use as well?
Oh, the use FOXO4 DRI. And usually the problem is it's expensive. So, it usually comes in 1 milligram and you can do like zero point 0.2 or something. Start with zero point 0.1 even, and go to zero point 0.2 or sometimes it comes in 5 milligram, but it's expensive. But start low because if you have a lot of senolytic cells, you're going to freak out. I went on a trip and I did a big dose of Foxo the first time I did it. Oh my God. I was at the airport and I meet this guy at a business meeting. He's like, "What's wrong with you?" I'm just sweating. Just like I do that all the time to myself. But yeah, so go slow with that. And also the dasatinib. And it says like 200 milligrams. No, don't start with that. 25, 50, and then you could add enough, 1500 fisetin and other of those,
What do you
supplements.
think of rapamycin, Ken?
Yeah, I don't know.
There's
Uh,
some
there
controversy.
there's studies on it, and it seems good for maybe for autoimmune, and I take it on and off. But I think lower doses are key. I think 5 milligrams a week is not a great way to dose it. I'd
Mhm.
say a milligram twice a week would be optimal currently based on the current literature.
Yeah. Ken, since we started late, are you fine to go on until 8 minutes past the hour? Because we started 8 minutes late. Are you?
Yeah, I'm
Yeah?
always I'm always Early is not good for me, but late is fine.
We have this in common and so much else as well. So, all right. So whoever wants to stay, stay, and we'll keep going for a little longer. Someone's asking about how these peptides affect the microbiome. Are the peptides that support helpful bacteria and limit or remove harmful bacteria, yeast, mold? So
Yeah.
someone's asking
So
benefit versus
interesting.
killing.
Yeah. So they'll improve the terrain for basically the microbiome to flourish. And like KPV is shown to selectively attack the bad bacteria and leave the others alone.
I had a patient who came to me, maybe she's even here today, um, who had 20 years of diarrhea prior to coming to me. Nothing else could resolve it except for KPV. She had a candida issue as well, and she was one of those highly sensitive patients, couldn't even start with half a capsule. We had to,
Yeah.
like lots of
What
patients,
I tell them
open it up, take a
is
toothpick dip.
yeah, I tell them to look at it for a week, then smell it for a week, and then lick it. Yeah.
Yeah, put it under the pillow.
Yeah. Yeah.
But
Dream about it.
but usually we start with a toothpick dip and work our way. I
I
think
like
maybe she
that.
was
I haven't used that. I like that.
yeah, I think it might have been four toothpick dips and the diarrhea after 20 years stopped. I mean,
See, and the thing is, it goes on, you forget all these cases that you've improved, that they've been everywhere, right? How many times was she scoped and how many times did she get antibiotics and which made the candida worse?
right, right.
Yep.
Yeah. Someone's asking if there's a peptide that might reverse an invasive basal cell cancer.
Oh, that is a whole nother topic. Again, high dose ivermectin and fenbendazole to start off with PNC 27. God, I just started doing cancer and it's just like, oh my God, oncology is even more barbaric than the rest of them. And this cancer doctor told me, why don't you treat cancer? It's so much easier than Lyme. And so I'm like, ah, and so I had this patient. I'm like, you know, I didn't want to do it because I'm not involved in literature day to day, right? I didn't want
Right.
to miss anything. But I'm
Yeah.
like, oh my God, they go to these cancer centers and they're offered chemo, radiation, or the integrated ones, they get IV vitamin C. I'm like, really? So, and the guy who reversed everything, he was probably on 30 things, and most of them peptides. So, yeah, and reversed it in 2 months and they had given up.
Yeah. I had someone ask
It was a
about
death
that.
sentence.
Yeah. I lost the question, but in general, so I can't read it out, but someone was talking about cranial cervical instability and they're taking BP-157. They just had injections done probably at Sentinel Schultz Clinic. I hope there are a lot of places which don't have their technology yet. Okay, but anyways, that's for actually I interviewed Dr. Centeno, so listen to that if you have CCI and hypermobility. But I've had a lot of success while my patients have been waiting to go to Centeno Schultz for injections or waiting to go to Dr. Paolo Bolognese for surgery for CCI. Just GHKCU injecting it subcutaneously in just in the muscles of their neck and or GHKCU creams, GHKCU just injected subcutaneously. It's really one of my favorites for patients who have cranial cervical instability. And of course, if you've got CCI, you probably have mast cell activation syndrome aggravating your CCI because the chemicals from MCAS will tenderize your already loose ligaments. So then I'm using TB4 in addition to GHKCU, BP-157 injections can also be very helpful
I
for that.
wonder if follistatin would help and strengthen the muscles, and it does also work on some of the ligaments.
It might, oh, another thing about GHKCU is that my patients who've had that sort of um, tingling underneath their skin, which I would have thought, hey, that sounds really Bartonella like. Actually, it's really helped to take away people's neuropathy. So not only for connective tissue, but also if you have
Yeah,
neuropathy.
and with
Well,
neuropathy, I love ARA 290.
yeah.
Yeah, and BPC, TB4
Hmm.
frag. Yeah, so yeah.
Hmm.
Yeah, we've had
Yeah.
good luck with neuropathy because I had some neuropathy from Lyme autoimmune, And I checked some new tests and it showed I have autoantibodies to my orexin neurons
And
that,
now what?
and so, I don't sleep. And those are for sleeping. So I'm like, oh my God, I'm never going to sleep. But so we're reversing that. But we're looking at, epigenetic genes that are activated. So it's kind of a whole new
Yeah.
world. Yeah.
Yeah. Someone's asking about the use, dosing, sourcing of lorazepam. Really, it is one of my favorite ones to begin with. And Kent, I hope you please start to make that because that'll make me very happy.
Yeah, the
Lorazepam.
reason we don't make that because it's a med.
Okay, I
So
get
we
it
have
from
to
the
stick with
compounding
natural.
pharmacy. Yeah. So whatever state you're in, you want to get that from a compounding pharmacy. Okay, that
Well, there are
works.
some supplements that have it, but I don't know if I'd trust it.
Yeah, honestly, the only oral supplements I trust are those from integrated peptides. Okay, or from
Oh,
a
okay.
compounding pharmacy. Yeah. Um, Someone's asking if KPV is effective for parasites.
Yeah, again, it showed with the fungal and bacteria, but no reason to believe it wouldn't be effective against parasites.
Yeah. So now, since we were on the topic of GHKCU, someone is saying they've been using it for years, but recently integrated GHKCU, which caused an increased level of pain and inflammation in the elbow. Is that normal? I have never seen that. I don't believe that's
Yeah.
GHKCU, or I could say, everyone is different. You may not be.
Yeah, is it related? If it is, the product, but you know, kind of suppressing it here, squirting out the other end. I don't know.
Let's see what else.
Yeah, you know what? I would add some of the thymic peptides and raise that immune system. So it sounds like you're lowering the inflammation. And I don't know the study with GHK how it does with TH1, TH2. I think it lowers TH2, but I don't think it raises TH1. So I would add a TH1, something that stimulates TH1, thymosin alpha 1, or TB4 frag, or
That
again, some
makes sense. Yeah.
injectables. And
Yeah, it might be
so
that it's an incomplete
yeah, so it's
new protocol.
suppressing, you're not getting rid
Yeah,
of the bug. You're just, suppressing it here, 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 putting out the fires.
I love it. That makes sense. Which is why we like to give people multiple peptides at the same time. So it's working at every angle possible that's necessary for that patient. Um, After a round of epithalon 10 days, is it still beneficial to take pineal pep?
Yeah, and the study with 10 days, and they say, 10 days on and then rotate it back in. Those are really for cost. Is they don't want it to be prohibitively expensive. And there's only two studies that did it that way were just for anti-aging, no studies on illness. So we'll typically do 5 days on, 2 days off, go 2, 3 months, take a week or two off and kind of go that way. And, and then people will self-taper too as they get better. So we typically don't do the 10 days because it's like, the 11th day, you may all of a sudden see dramatic improvement. Um,
Yeah.
yeah.
Thank you,
Okay.
everybody, for
Thank you
joining
so
us.
much.
Yeah,
You're the best.
you
Bye,
are.
everyone.